Sachin, you're on live. Then we can start the meeting, guys. Shruti.
Yeah, okay.
Can you
Okay,
share
okay.
audible?
Ah, yes. Yes, Akshay.
Thank you.
Am I audible? Yes, yes. But can you increase your voice?
Am I audible now?
Yes, yeah, you can start.
Yeah. So, good evening to one and all present here. And I'm Pandit Ministry, member of IMA-MSN. So, tuberculosis is a disease of poverty, but it is also a disease that perpetuates poverty. This powerful reminder reflects the importance of awareness, education, and action in public health. With this thought, I want to welcome you all to the today's insightful webinar titled What Happens in a National Program and Insiders Insight, organized by the Indian Medical Association, Medical Students Network, and Junior Doctor Network, Tamil Nadu State Branch. Today's session promises to take us beyond textbooks and into the real world functioning of National Health Program, an area that shapes the backbone of community medicine. A good beginning sets the tone for a meaningful journey. To formally welcome our gathering and set the stage for today's session, I invite Shruti Shivakumar, Academic Subcommittee Head, IMA-MSN TNSB, to deliver the welcome address. Over to you, Shruti.
Thank you, Pani Vinashri. So, good evening to all. It gives me immense pleasure to extend a warm and cordial welcome to each one of you to today's webinar titled What Happens in a National Program and Insider's Thought. We are truly honored by your presence and grateful that you have joined us for this insightful academic session. I would like to begin by respectfully welcoming our esteemed patrons and dignitaries. Dr. B. Sridhar Sir, State President, IMA TNSB. Dr. P. Sengotavan Sir, IMA Past President. Dr. N. R. Tyagarajan Sir, President elect 2027. Dr. A. K. Ravikumar Sir, President elect 2026. Dr. M. Tiravya Mohan Sir, State General Secretary, and Dr. D. Solomon Jaya Sir, State Finance Secretary. Your leadership and guidance continues to inspire the medical fraternity. We are especially privileged to have with us today our distinguished speaker, Dr. P. SRIRANGANATHAN Sir, Associate Professor, Department of Community Medicine, Srinivasan Medical College and Hospital. Sir, we are truly grateful to you for taking the time to share your valuable insights with us. I would also like to extend a heartfelt welcome to our organizing team and office bearers, Dr. R. Annamalai Sir, Chairman, IMA MSN TNSB, Dr. S. Jamnavani Ma'am, Co-Chairman, IMA MSN TNSB, Dr. Kannan Rajendran Sir, Convener, IMA MSN SC, and Dr. V. S. Hariharan Sir, Chairman, IMA JDN TNSB, along with Arun Giri Sir, Convener, Ajay Karthik Sir, General Secretary, Hariram Vijay Sir, Co-Convener, and Bala Hariharan Sir, Co-Convener, and also our dedicated state and organizing team members. Your hard work and commitment have made this event possible. And finally, I extend a warm welcome to all the participants, medical students, interns, and young doctors who are the backbone of the initiative. Your enthusiasm for learning and growth is truly commendable. It's an eminent gathering and an insightful topic ahead. I'm confident that today's session will be both enriching and inspiring. Thank you all once again for joining us, and let us look forward to a productive and engaging session. Thank you.
Thank you, Shruti, for that warm and gracious welcome. The right introduction is not just about credentials, but about connecting us to the mind behind the knowledge. To introduce our esteemed speaker of the day, I would like to invite Akshaya TR, Academic Subcommittee Member, IMA MSN TNSB. Over to you, Akshaya.
Thank you, Pandi Meenakshi. Good evening, respected faculty and my fellow students. It's my privilege to extend a warm and heartfelt welcome to our esteemed speaker, Dr.
Akshaya,
She was in Medical College and Hospital, Trichy. With over 9 years of hello, sir.
I guess your voice is breaking. Can you please do it again if you don't mind?
Okay, am I
Yeah,
audible
sorry to
clearly right now?
interrupt you. Your voice is actually breaking. Yeah, now
I'm
you are
audible.
audible. Can you please start again?
Okay, thank you. I'll
Yeah,
start
now you are
again.
audible, Akshaya.
Okay, good evening to all, respected faculty and my fellow students. It's my privilege to extend a warm and heartfelt welcome to our esteemed speaker, Dr. T. SRIRANGANATHAN, sir, Associate Professor, Department of Community Medicine, Srinivas Medical College and Hospital, Trichy. With over 9 years of dedicated experience in public health, epidemiology, and infectious disease control, he has made significant contributions to both academic medicine and national health programs. SAR has worked closely with the WHO under the National Tuberculosis Elimination Program, gaining valuable field level insights into functioning of large scale public health initiatives. His expertise in bridging theory with real world implementation makes him an ideal speaker for today's topic. What happens in a national program? Insider's insight. His commitment to research, community outreach, and medical education is truly inspiring, as reflected in his numerous publications and active involvement in professional bodies. On behalf of everyone present here, I extend a sincere gratitude to you, sir, for taking the time to share your knowledge and experience with us. We eagerly look forward to an enlightening and insightful session. Thank you.
Thank you for that wonderful introduction, Akshaya. Knowledge shared is knowledge multiplied. It is now my privilege to welcome our speaker, Dr. T. Srinanganathan, sir, Associate Professor, Department of Community Medicine, Srinivas Medical College and Hospital. Sir, we are honored to have you with us today. The stage is yours now. Over to you, sir.
Thank you for the nice words of introduction and thank you for the wonderful organizing. I'm now sharing my screen. Okay. Yeah, is my screen visible?
Yes, sir. Yes, sir.
Am I loud and clear?
Yes, sir.
Okay. So I don't want to go deep into the theoretical aspect of it. I want to be more of an interactive session. So WHO or any national health programs, even in from India, has been a bucket list for most of the public health enthusiasts. That's students who are doing either MD in community medicine or even diploma in public health or masters in public health. So we all fantasize some of the positions or jobs or some of the programs, but let us know what they're really doing at a grassroots level and what is the need of the harbor for those particular programs. So today's topic is as an insider's perspective on a national health program. So I was working with National TB Elimination Program, that is NTEP, the district of Kurnool for Andhra Pradesh, and I have been a consultant for some around 6 states, 6 districts. So how this works and how the functionaries of TB consultant, field medical consultant works is what we are going to see in today's session. Hold back all your queries for the end of the session, and I want to have an open-minded forum discussion at the end of the session. So what we are going to see today is what is India's TB burden, what is NTEP was about, what is the role of me being a consultant, what is the program in action, how it works, what are the challenges and gaps that we find, and what are the lessons for our future budding doctors. So this is what we are going to see today. So it's going to be a very short session, and I need more of a discussion out of it. India is being the country with much bigger population junk. What happens is the chances of it getting of the communicable diseases is very high, and India ranks number one across the world in TB burden. We share at least about 27% of the global new TB cases, and all the cases are being reported in India. Whereas the target year for eliminating TB is 2025, but still we are finding new cases. The problem with TB is TB doesn't fall under a distinctive category of being into a a disease which gets a complete cure. Whenever the immune body's immune status is being low, the disease re-emerges, and it is one of the most important re-emerging infection. Since being an airborne infectious disease caused by mycobacterium tuberculosis, it is being omnipresent and omnivalent. You are all exposed to TB. That is why the test of MAN2 isn't a test of identification or for a diagnosis of TB. So India has declared TB a notifiable disease under NDEP program, which was formerly an RNDCB program. The TB burden has been a major chunk of India's expenditure, and India's PM has taken the program of TB Mukt Bharat Abhiyan, which targets to eliminate by 2025, which we are not done, and we are working still in the process, and we are moving to 2030. And it is one of the number one infectious killer disease, despite its being preventable and curable. Is my speed okay, or am I going fast?
Yes, Paka, sir.
Okay. This is how the National TB Elimination Program has rolled into play. First, National TB Prevention was planned, launched in 1962. Then RNDCB was formed, Revised National Tuberculosis Control Program. Later, it was emerged as a DOTS Plus program, that is a directly observed treatment short course, where it is mostly done for people with drug resistant tuberculosis. So people ought to have challenges like continuing the TB treatment despite of the adverse effects that they are going to have for once they consume all the TB drugs. So what happened? They failed to continue the drug, and the drug adherence was very low. Patient had a very nice a policy of having a compliant drug. Whenever they are having a drug and they are not having a trouble with the drug, they continue the TB drug. And specific drugs, when they are having adverse effect, they stopped it. That is where this DOTS program was initiated to ensure that we are visually looking at the patient consuming the tablet. Then in 2012, we formulated the Universal Drug Sensitive TB program, and in 2020, it was renamed into National TB Elimination Program. So I worked with NTEP between 2020 to 2021 at the verge of the COVID pandemic. So most of the diagnosis of COVID were even made with the TB missions. Though India is having a higher technology in identifying and diagnosing TB, but the problems what we have faced are totally different. So what are the functions that we are going to do under this program is, first one thing is the identification of cases, that is case detection. So we do active surveillance, passive surveillance. And the main modality which was used previously was microscopy, CBNAT, TrueNAT, and line probe assay. Then comes the treatment protocol. The treatment, as you all know, there is two lines of treatment. The first line and second line of TB drugs are there. Based on the sensitivity pattern, we are going for the standard treatment. Then the program aims in continuous supply of drugs, uninterrupted supply of quality assured anti-TB drugs to be availed for all patients from anywhere in the country. You can get it even through courier. You can get it from any other district headquarter hospital, irrespective of your locality. Recording and reporting of all the vital data of a TB patients. We are having a wonderful software called as Nikshay. It's a platform, it's an online platform. How you use a Google and how you use a Facebook. So this Nikshay is Pakka planned program for enlisting and monitoring, recording and reporting of all the TB patients. It is called as a Nikshay. Nikshay. Then the program also commits itself to provide nutritional support to the patient of rupees 500 per patient. That was in the previous one. For a drug resistant tuberculosis, they are paying up to 1000 rupees. This is for a DSTB. For a multi-drug patient, the programmatic management has even free second line drugs till the latest introduced drugs of bedaquiline and delaminate. These are the latest drugs. I will just highlight certain points here which will be used for you for if you are preparing for your NEET postgraduate exams. So the latest drugs which have been formulated are delaminate and bedaquiline. These drugs are used in all oral therapy where the patient is going for a multi-drug or an extensive drug tuberculosis. The patterns of resistance vary from a monodrug resistance to an extensive drug resistance. Monodrug resistance is either one of the first line of drug, either rifampicin or isoniazid is resistant. If there is a single drug resistance in rifampicin resistance, it is called as a rifampicin resistant tuberculosis. More than two first line drugs, it becomes a polydrug resistant TB. More than two drugs, it becomes a multi-drug. If all the drugs of first line are being resistant to the TB, then it becomes an extensive drug resistant tuberculosis. So, what is the role of a WHO national technical support consultant? What am I expected to do at a field level? When I was availing for this job, the first ideology behind that is okay, I'm achieving something which I wanted to do from my PG first year days. But the ground reality is totally different. You won't get the concerned jobs in your locality. The basis is purely based on the underperforming states or where you are being placed. So I was being placed in a overperforming state. That is, Andhra is being number one in the all the statistics. So that becomes an additional trouble when you are going as a field consultant because already an overperforming state, we think it is going to be a cakewalk, but the problem is totally different. So these were some of the core responsibilities which I had, and I will be sharing you about what are the problems we had while catering or delivering our responsibilities. The first thing is supporting the district TB officer (DTO) in program monitoring and supervision. These positions are being occupied by people who are specialists in pulmonology. So these are the district TB officers. So they will be facilitating the program at district level, or each district will have an district TB officer. Then we have to do a routine field visits to all the peripheral health centers. These are peripheral health centers are nothing but your district consists of so many PHCs and designated microscopic centers where you are supposed to see and look for how the process is being done. You have to look through the process of capacity building and training for field staff and also follow the treatment outcomes. How will we follow the treatment outcomes? The treatment outcomes will be followed only through Nikshay. The Nikshay is an Pakka organized platform where you can see whether the patient has consumed the drug, the patient has turned up for the next visit, or the patient has taken the post intensive phase screening. All these things are all followed by this Nikshay software. Coordinate BMDD services for multi-drug resistant tuberculosis, license with private sectors in involving them in public-private partnerships. Public-private partnership is an initiative where we take corporate hospitals and medical college hospitals, private medical college hospitals into our program, and we make them as partners in contributing towards the welfare of the community. Also, we report monthly and quarterly data to WHO India as well as the state TB cell. The Central TB Division is the headquarter for the program of NDEP. NDEP is an India run program. Though we are WHO consultants, we have been uh, supported directly by the WHO to facilitate the normal functioning of this program in India. And also, one of the main more responsibility of an WHO consultant will be heading the operational research of tuberculosis in your controlled districts. Because TB being an infective disease and the data is also being highly sensitive, this is a confidential data what we are handling. So you are being the head of then operational research for the districts which you are taking care of. How NDEP operates to the ground? When we are seeing about the public health infrastructure in India, the foremost thing what we see is a sub center. Sub centers don't have a facility for TB, so the next will be your primary health center or PHC. These PHCs do have a designated microscopic center, that is a DMC, where they have a light microscope and they do all sputum examination of zeal instrument technique. They do the staining, zeal instrument staining, and look for acid fast bacilli, and they register the case and they start the drug. This is how it was previously done. And even in Tamil Nadu, at the places they were doing this. Then they are being sent to the next a PHC level or a community health center or a TB unit where they are being provided with drugs at a dot center by a medical officer. A medical officer is the head of the TB unit. Then comes your district TB center or district TB unit, which is being headed by the district TB officer. This district TB officer mostly is in the district headquarter hospital. So he is responding directly to the district collector. The collector is the responding authority when it becomes a national health program. He becomes a mission director at the national level for all the national health programs. So when you are working in a national health program, it becomes ideal that you are answering directly to the collector. There is no other bosses. You have to report directly to the collector whenever there is an issue. Then comes your state TB cell. The state TB cell will coordinate with all the district TB cells in efficient functioning, training of the faculties, training of the staffs, grassroots level support, and even with simple minimalistic things, the state TB cell will take care. When at the national level, we have a central TB division, CTD, which frames the policies, guidelines, and fundings. All these fundings what we get are fundings of the Ministry of Health and Family Welfare that we are getting for this program. So the central TB division is a holding authority for all the state TB cells. So how it works? A group is the NTEP infrastructure is being there from district, from state to ground grassroots level, and WHO consultants are also placed from central TB division till the district level. So a consultant will be looking after some 5 to 6 districts. Then comes a state headquarter consultant who will be reporting directly to the state TB cell and state TB officer. Then we have a regional team lead. A regional team lead will be a senior faculty who will be looking after 2 or 3 states together. Then comes the CTD. We have some around 6 regional team leads, India being divided into south, central, north, east, and west. And we have two south actually, because India being a bigger state, we have Tamil Nadu and Kerala having a common regional team lead, and we have for Karnataka, Telangana, and Andhra, we are having one more team lead. So we have some 6 team leads who are leading us in the front. This is how the organization structure of the NDP works. So we work in pair with the Ministry of Health and Family Welfare's National TB program. The consultants are part and parcel of it. So how it works? So how we are going to the grassroots level? First is the diagnostic algorithms. Previously it was chest X-ray with clinical finding. Then we did sputum microscopy. But the ideal choice of a diagnostic modality will always be your CBNAT. CBNAT is your molecular diagnostic computer-based nucleic acid amplification technique. It is a gene expert where it finds the gene of your from the sputum and it do an PCR, a polymerase chain reaction, and it codes the imprint and identify the resistance pattern as well as whether it is TB bacilli is there or not. So when you are doing at CBNAT, you get to know 2 things: when there is rifampicin resistance is present or not, then whether there is TB positive or not. 2 things are being there. Then comes your TrueNAT. TrueNAT is a similar kind of nucleic acid amplification technology, but it is used mostly at a designated microscope level or a PhD level. So what they do is they have 2 chips for it. One chip for identifying whether it is a TB positive or not. Then other thing is for identifying rifampicin resistance. So you are supposed to run 2 times a same test, and most of the times the TrueNAT are a unimodular machines. Only one test you can do. Whereas a CBNAT is a you have mono, duo, and quadro. You can do a single sample testing or up to maximum of 4 sampling test techniques. Then comes your line probe assays. So this we usually do for people with multi-drug resistant tuberculosis or extensive drug resistant tuberculosis. We send them for drug susceptibility testing. So once you send the sample for drug susceptibility testing, you will be identifying what are the specific drugs the patient is sensitive and resistant to. Then comes your culture. Usually culture is a supporting evidence rather than using as at the diagnostic or a therapeutic or treatment pattern, because culture takes more than 6 to 8 weeks of time, which will be a very valuable time in providing treatment for the patients. Rather than various planning and programming various diagnostic algorithms for the patient, we go for active case finding. Active case finding is nothing but we go for active surveillance. We go to house for symptoms of screening in high risk areas. So we go for identify a patient with TB, then we screen the surrounding areas with the contact history of all the family members, including the kids we do, and also we do regular screening for people who are vulnerable. The vulnerable populations are always pregnant women, people with immunodeficiency or immunosuppression, and also people with living with HIV. So some of the tests which were being done were X-ray screening was done in tribal and migrant communities. Then we have a plan of Nikshay Mitra. Nikshay Mitra is nothing but providing nutritional support by other community support people. Like even our institution is being providing nutritional support to some 50 patients of drug sensitive TB. We are providing them with rations for 6 months. And then we are also involving identifying the private practitioners in the area and made them mandate to test for TB and also to notify when a TB case is being found. As we all know, then comes our the modality for treatment for drug sensitive and drug resistant TB. So we have 2 HRZE and 4 HRE for 6 months. This is for a new case that is being found. So this is a treatment for 6 months, 2 months of intensive phase and 6 months of 4 months of continuation phase. Then comes the previously treated case who had a relapse or there is a loss to follow up, where we go for 8 months treatment. In a pediatric TB, we go for 6 months of treatment based on weight base. TB preventive therapy is being given to people following an IGRA test. IGRA is immunoglobulin test. That is a similar kind of a man-to test, but it is done mostly in a contact person. And once they are diagnosed with exposure to TB, when during the incubation period, we give them a TB preventive therapy. All drugs that are being provided under this national TB elimination programs are provided free of cost, just to reduce the out-of-pocket expenditure of the patients to 0 rupees. The patient need not spend a single penny for getting the treatment for tuberculosis. Then comes your drug-resistant TB. Multi-drug resistant TB are being provided with bedaquiline, linozid, as well as clofazimine regimens for 18 to 24 months. Then comes your extensive drug resistant TB, where we are going to give bedaquiline, delaminate, and clofazimine. Then comes your drug sensitivity testing. We do an LPA, line probe assay. Then we look in for the patient for an adverse drug reaction. We provide psychosocial support, and also we monitor the treatment outcome. The treatment outcomes, how it is classified are, they are being classified into cure, completed treatment, they are failed treatment, died or lost to follow up. And one more important thing with um, the follow up is, once a patient has completed his treatment, once he is being notified, there isn't a follow up, but how it is being done is they are seeing for the welfare of the patient. So the patient gradually improves the quality of his lifestyle. That's why we are being providing them with various nutritional support. Due to the various adverse reactions are being provided in the simple drugs when given alone. Now the government has framed a unique way of doing a combined drug therapy approach. A combined drug therapy approach is a combination therapy where all the drugs are made into a minor quantity and mixed into a single tablet, so that the patient will have a better drug compliance and drug adherence. So that is how it works with the combination drug therapy. So this is the ground reality of what we are facing. So the main problem is with the stigma and social barriers. So TB is not a disease of the poor. It has become a disease which is brand. It's like a band which is seen. It's a spectrum which is seen across all sectors of the society, because most of the time you see non-communicable diseases among the wealthy population. And in the wealthy population, even this non-communicable diseases like where there is a cancer due to smoking or there is diabetes mellitus, you get to have an decreased immune response and the patient develops TB. And also, I always say it in my classrooms whenever I'm going to see my students and taking a TB class. Always eat before you go for your clinical postings, because you are going to be the most exposed and most vulnerable population. I've seen that even students developing tuberculosis when they become interns or once they get married, they are becoming pregnant, because pregnancy too is an immunosuppressive state. There, the infection spreads because the stress being hunger being a bigger stress in the interns who have an habitual way of skipping the morning breakfast is being a big trouble for them. So always remember this in mind and teach it to your fellow friends. Non-notification at private sectors. Why non-notification? Because people have a thing that TB is a stigma and it has to be confronted to a single person and not to anybody, even for a family member. It happens because you see, patient, even if you go to a TB ward, you move out of it or you close your face or you put a mask and you stay away from a TB patient. How many of you are comfortable with seeing a TB patient? But the thing is, the chain of transmission is only for a period of 2 weeks for a drug sensitive TB case if you are initiating the treatment. And also be cautious, any drug resistant TB, a patient becomes resistant to drug, any one of the first line drugs, and it becomes a case of drug resistant TB. Any other person who is contacting from him is also becoming drug resistant TB case. ஒரு பேஷண்ட்டுக்கு ட்ரக் ரெசிஸ்டன்ஸ் வந்துருச்சுன்னா, when he starts becoming the source for spreading the infection, there the problem is he's spreading drug resistance TB. Always, as I said, this being a disease of the poor, it is mostly you are having people who are malnourished. That's why the program is providing them with nutritional support of 500, because they tend not to go to their jobs and they have to have an additional calorific intake, a protein intake, which we all suggest for any disease recovery. Loss to follow-up cases are mostly missed due to various adverse drug reactions. So we are having a unique way of tracking all these people with their mobile numbers. If they tend to fail to reach the hospital to get the drugs, we follow them up and get it done. And also we have a crunch at human resource, right? This STLS or STS are senior treatment supervisors and senior treatment lab supervisors. These are the people who are sitting down at the ground level and working with the patients. So they are having a larger chunk of the population which they have to do. And mostly these people are non-medical people. Lab people is at least a lab technician. Whereas an STS is a non-medical people. So there are ideal chances that they get stressed out in the peer pressure and they leave it out of the network. That's why there is a vacancy, huge vacancies being there, and burnout is being visible. And the TB MO, medical officer, is also made to manage 4 to 5 TB units, which is an impossible task to do because nobody is happy about going and working in a TB unit. The stigma is the main reason, and more than that, there are high likely chances it being an infectious disease. You're ought to get an infection when exposed to the particular illness. Then comes the comorbidities. We screen for two comorbidities in a larger extent: TB HIV co-infection and TB diabetes mellitus co-infection. These two are seen in a very massive scale because diabetes is an immunosuppressive state, HIV is an immunocompromised state. So Nikshay is India's digital TB management system. What are the things we see in Nikshay? We first do the patient listing there, patient registration. Then you see for Nikshay Bhojan payment, we enroll the account number and mobile number of the patient and follow them. Then there is a private provider notification is there. So you can identify from whom the notification has come, who is the contact person, who is the contact TB unit. Then you can upgrade all the lab investigation and results to that. So a doctor can directly see the Nikshay and see for the patient's result rather than going asking the patient to get it or going to the patient to see it. Then once the treatment is completed, the outcome reporting is also being generated. So you can see how the outcome has been. And then there is drug supply monitoring, which ensures uninterrupted supply of drugs. Then we follow contact tracing. We enlist the fellow members of the family and follow them. Then we also see each and every patient's treatment is being tracked. So Nikshay, we as a consultant, we are asked to, just like we are checking our Instagrams, we used to enter into Nikshay to see what is the actual census or actual thing going on. We're looking after some 6 or 7 districts. It'll be very difficult, and at times we get to get calls from people from the district saying that sir, we are having a glitch in this. That is, we are finding it difficult to access the Nikshay portal. So that is where the consultant's role is to. The consultant should know what the things are there in your Nikshay portal and help them out in the TB. An ideal role of a consultant is to bridge the gap between the NDEP people and the public people, and we want to integrate them and make it as friendly as for everyone. So lessons which medical school didn't teach me, similarly, which even we are also not teaching you, because these are some unique skills which you ought to get, but some things are non-negotiable. You see, how to diagnose a TB patient or how to diagnose a case of a TB is considered as a social act. You see, any patient coughs, you see, you tell them, okay, maybe you may be having a TB, but that isn't the same. There is a criteria called as a presumptive TB, cough more than 2 weeks, fever more than 2 weeks with a significant weight loss, hemoptysis, and chest pain. Are these are some of the common symptoms. If 2 or more of the symptoms are present, we consider them as a presumptive TB case and proceed with the treatment. A positive sputum smear means nothing, but if the patient doesn't come back, you are supposed to follow up the patient. The patient may be an ideal source, and it is a point source, creating a point source epidemic. The problem between a clinical medicine and a public health is the gap is very big because the program planners and implementers are public health people, whereas the clinical people who are going to follow the treatment are just sticking on with the protocol of the treatment rather than making sure that not just the person is a problem, his environment and public is also being at a major problem. Programs are good as a people because the staffs, when they are being short numbered, you ought to encourage them, you ought to motivate them because they are being getting a very meager pay and their dedication for the job is just for the mere being a breadwinner of the family. So always run the program by making it tapping, giving them a tap on the shoulders for all the appreciations they are doing. That is how a good consultant works. Data driven decisions are mostly based on statistics. You see, statistics is what every state expects a consultant to do. We want a ranking, no, a podium. We always want to stand in one among the three podiums. But that is not how it is done when it comes to infectious diseases. An actual case finding and actual testing will never get you into the podium. But it is a number game, and you be part of the system. You are forced to do that. Stigma kills more than TB does. Of course, it is. It is a responsibility of the doctor to counsel the patient and his family members in including them as part of the treatment plan. Ask them to get their family involved in providing them with nutrition as well as for adhering to the treatment pattern. And also, TB is an non-negotiable when it comes to intersector reliability because we just don't treat that person. It is a clinico-social competence is what is expected out of each and every fellow doctor and fellow healthcare worker who is working at a grassroots level. So this is how it works, and you will be the program when you are following what and all has been learned as a lessons of your experience. Every patient you diagnose is a statistic that becomes a person again. Every default you prevent is a drug resistant case averted. Every TB free village is a community you help with. Notify every TB case, counsel even a small patient if he is having some kind of an ARI symptoms, collaborate with grassroots level healthcare givers so that you will identify the problems at a grassroots level. I had a problem of the minimum balance being deducted out of all this Nixai Bojan um, accounts. Whenever I'm putting 500 rupees to a patient, the patient is telling me, sir, I am not able to take money out of it. I ask, what is the problem? Then they tell me, sir, I have a minimum balance, sir. Only I have zero balance. They put 500, they took 150 for charges, minimum balance penalty. It becomes 350. Again, next month, when it comes, they have the minimum balance charge for 350, the 500, again, they're deducting 150. Then we intervene and we ask them to go for a Jandan account. Jandan account is an account where there is a zero balance is maintained. So we made sure that all the people are having a Jandan account so that even a single rupee or single penny is not being left out from their pocket as the program denotes. Ending TB is not just a responsibility of a single consultant, it is always the responsibility of the total community. And I had a craving for teaching, and I wasn't having that much of a way for helping out the people there. So I thought it is always be at a place where your heart is. That is me being with my students. Then I came back from WHO, and now I am working as an associate professor in a medical college. And that's all for today. And the last thing is the theme for this year is yes, we can end TB. So this is led by countries and powered by people. We have 83 million lives that have been saved since 2000. 10.7 million people have fell ill with TB in 2024, and 1.23 million people have died of TB in 2024. Though being a preventable and curable disease, we tend to lose a bigger chunk of the people. The mere reason is because the lack of awareness and lack of knowledge. Spread this awareness about TB to each and every one of your fellow member and family people. This isn't a stigma. This is again a disease. This is again a disease which can be cured and can be treated. Thank you so much, Jai Hind.
Thank you, sir, for this incredibly enlightening session. Your insights have truly given us a deeper understanding of how national programs function behind the scenes. And last week, we, the people of IMA-MSN, literally had a debate in the title. What is the involvement of public as well as the government participation in ending the tuberculosis? So we, the people who have participated in the debate, have got the answers via this beautiful and insightful session. And really, thank you for that session, sir. And curiosity is the spark that turns information to understanding. We will now move on to the doubts and discussion session. I request all the participants to actively engage and clarify their queries. I request every participant who have doubt to put their doubts in the chat box.
Sir, I have a doubt, sir.
Yeah, Bata.
Sir, we have been speaking TB since 19 from the 1990s till now,
Yes.
and we have at least from let us speak from Tamil Nadu's perspective, sir. We have almost around 72 medical colleges, and we have covered almost all the districts across Tamil Nadu. But yet, we still have cases of drug-resistant TB and newly diagnosed TB from the previous context or poor patient compliance, sir. Is it the lack of awareness among people, or is it that the efficacy of medical colleges approaching, or the medical institution approaching the common public is lacking between them? So, what is it? What is your take on that, sir?
Actually, it goes both the ways because people, those who are treated with TB or who have got cured with TB, are also having a likely chance of getting a relapse at some point of time. The patient may not be having the apt knowledge about the particular thing. That is one thing. And the other thing is, whenever you are going for an immune suppression, you get a chance of re-emerging of TB. That is another major problem. And the major problem with varicose, as I said, most of the times I used to tell, you see a respiratory case, you auscultate them. Once they become a TB patient, only you become aware that, oh, I inspected the case, but I wasn't aware that that was a TB case. So always follow the universal safety precautions, which we are not doing. That is the one thing. With regards to healthcare institutions in private and public, the problem is private hospitals tend feel difficult in handling TB cases because once the case is being admitted in your hospital becomes a source. They fear that it is an airborne infection. If you don't have a proper airborne infection control program in your hospital, that same ICU becomes an infective source for most of the patient. So they avoid doing that. That is wrong actually. You see, the TB is for you treat them for 2 weeks and the patient becomes put negative. You're cutting a big chain of transmission just with mere treatment for 2 weeks. And also there is a political commitment as how the family planning was implemented in 87 as take a big hit on the government. Similar way, if we want to do TB elimination in hard and fast method, people will not like it. People will not take it. Even for a TB preventive therapy, when you are giving drugs for the patient's family members, you are going to give drug to a patient family member. So what happens? The family member will think, why am I supposed to eat a TB drug? I know that is a TB drug. I know it will cause adverse drug reaction. Then how will I do that and why am I doing that? The need of commitment from the family member in ensuring the patient's adherence as well as his participation in the patient's treatment plays a role. It is a multi-sectoral thing we have to do and get it done. Hope I had answered your query.
Sir, yes, sir. Sir, do you think that we are going for family adoption visits every year, at least 5 6
Yeah, yeah.
year? So, can't the NTP program integrate with family adoption program? Sir? We are asking so many questions with respect to their family or their nutrition. Don't you think TB is something that can be addressed from the performance, sir? Like the first year or the second year student cannot go and speak about TB,
Yeah,
but
get it, get it. You see, that's why we do field programs. We brought patients to a hospital to give them nutritional support. We go to the community, deliver health talks on that. These things are being done to educate them on that. But again, the problem with asking a student to go to the field level for identifying a TB case, it becomes an intensified case finding. The various types of surveillance, active, passive, and intensified case finding. It becomes an intensified case finding. The problem is again patient opening up to the student. If you go out and ask them what you had for your breakfast itself, they are finding it difficult to get from the families. Then if you are asking them a TB question or a HIV question, it is considered still as a stigma in the rural people. You see a person who is smoking from the morning, that person have a potential capacity of getting TB because once he smokes, the respiratory alveoli and the epithelium is going to get changed. It's going to derange, and the likely chances of TB bacilli entering his system is very easy. But we can't do it at a grassroots level. The problem is it has to be a patient involved or patient derived way of getting screened if he is having symptomatology for more than 2 weeks, like a presumptive TB symptoms which I was narrating. If you are doing that, it will be convenient. Else, it is quite difficult to do it in a family adoption program. And again, the problem with family adoption program is you are doing it from first year. You getting sensitized with all this TB and all these things being forced down upon you will be only in the third year. That is the difference. So I wanted to add another point on this. Any person who is want to pursue being a WHO consultant, WHO has job opportunities now in three sectors. One thing is an NPSP, National Polio Surveillance Project, and NDEP and NCD. NDEP and NCD are not directly run by the WHO. These are support programs where the financials are being done by the WHO, and the Ministry of Health and Family Welfare is doing the job recruitment on all the other things. You be a extended technical support network consultant. So these are the two entities for PGs who are doing masters in public health. Either you do an MPH or a DPH. The MPH will be a preferred one, or a MD community medicine. You likely have a chance of becoming a consultant in the future. The beautiful thing about NPSP is, though polio was eradicated, you still, for surveillance, you are still recruiting consultants, but most of the times you will be getting those opportunities. This is NPSP is a direct WHO's job position. You get your pay in dollars, and you will be getting only in most of the countries of states of northern India, like Uttar Pradesh, Chhattisgarh, or Orissa. These are the places. Bihar are the places where you get your postings from.
Thank you, sir.
Thank you everyone for your active participation. Gratitude turns a gathering into a meaningful memory. To express our sincere thanks, I would now like to invite Srimant Ram, Academic Subcommittee Member, IMA-MSN TNSB, to deliver the vote of thanks. Over to you, Srimant.
Thank you, Pandi Minashri. Respected dignitaries, esteemed speaker, and dear participants, on behalf of the Indian Medical Association, Medical Students Network, and Junior Doctors Network, Tamil Nadu State Branch, I take immense pleasure in proposing the vote of thanks for tonight's insightful webinar on what happens in a national program and Insider's Insight. First and foremost, I extend our heartfelt gratitude to our esteemed speaker, Dr. T. SRIRANGANATHAN sir, for sharing his valuable knowledge, practical insights, and real-world experiences. Your session has truly enriched our understanding and inspired us to explore national health programs more deeply. I would like to express a sincere thanks to the esteemed patrons of the IMA-TNSB for your constant guidance, encouragement, and support in making this academic initiative possible. Our heartfelt gratitude goes to the state team IMA-MSN TNSB, whose leadership and coordination ensure the smooth execution of this event. I would also like to acknowledge and thank the organizing team comprising of Shruti Sivakumar, Parthasarathi S. Sir, Vigneshwaran V. Sir, Sachin Sir, Vishal Manohar Sir, Akshaya Akshamam, Pandi Meenashrivam, and Shrivan for their tireless efforts behind the scenes in planning, coordination, and technical support. A big thank you to all the participants for their enthusiastic involvement and active engagement, which made this session lively and meaningful. Lastly, we remain grateful to IMA for providing such a platform that fosters learning, collaboration, and professional growth among students and young doctors. With this, we conclude today's session. Thank you all once again for your presence and support.
Thank you, Srivan. With that, we come to the end of this today's session. Learning never exhausts the mind; it only ignites further. On behalf of the organizing team, thank you all for joining us. We hope you to see you again in many more such enriching events. Have a pleasant and enriching evening ahead. Thank you all. Thank you, sir.
Thank you, Bada. Thank you, Pandimini. Thank you.
Thank you, sir. Thank you, Rekha ma'am. Thank you, ma'am. Thank you, sir. Sir, okay.
Yes, Bada.
Sir, you forgot to add about self-defense, sir.
So you want a real-time self-defense or defending yourself from TB?
Both, I guess.
I will give you a class on self-defense. Yeah, one good thing about proper nutrition is the only way that can protect you from TB. The only simple, easy fact is being nutritious, being healthy. You see, any viral infection happens, anything happens, you are going to take The only nutrition is the only key choice. And I see major people, vegetarians, being affected with tuberculosis is one thing, and other thing is people who are having a very lean body mass, or people who are skipping the breakfast. These are the common malnourished people whom we see, and this is the only self defense we can do it against TB. We don't have any other choice here because TB is a much preventable disease. Like how we see tetanus, no, it is a 10 rupee injection we are giving. Similar way, TB is there. But if you leave a way for it to happen, the damage it can do is totally irreversible. So that's simple it is. I self defense I will teach you in person and meet. Okay, Partha. Thank you so much. And this is
Thank
a
you,
very
sir. Thank you,
good
sir.
effort by you youngsters doing budding doctors doing it. Always feel free to communicate to me. You can communicate to Partha and get my details if you want any specifics on this or insights on this. And also have in mind that whatever you are doing in your post graduation, it is only your attitude and your skill matters. It is not about the specialty. You do a community medicine, you become a world health consultant. You do a microbiology, you become a world health consultant. You do a tea pulmonology, you become a consultant. You do a general medicine, you become a consultant. It is not about the stream what you're doing. It's your perseverance is what is going to get you there. And also remember, WHO is not all everyone's cup of tea because it leads to extensive traveling. I didn't tell the negative shades of it. I tell about the fancier aspects of getting a chauffeur-driven vehicle and all the benefits out of it. But it needs extensive traveling. You are posted in some vague places where you don't have access. You travel for 16 hours in a car. It all happens. It does have its own merits and demerits. Thank you so much for the opportunity. Stay in touch. Always have a urge or hunger to learn or to explore a thing that will drive you to a very nice place. Thank you so much, guys. Take care. All the best.
Thank you, sir. Thank you, sir. Thank you, Rekha, ma'am. Thank you, ma'am. Thank you, sir. Vignesh, you can end the live and meeting too. Thank you. Thank you very much.
Okay.